Hello everyone and welcome to Blood and Hematology YouTube channel. This video is about monoclonal B-cell lymphocytosis and its definition, diagnostic criteria, classification, and laboratory features. Monoclonal B-cell lymphocytosis, MBL, is an asymptomatic hematological condition characterized by a circulating population of clonal B cells with an absolute count less than 5,000 per microliter, and the absence of any clinical features of CLL or other lymphoproliferative disorder. The prevalence of MBL, depending on assay sensitivity and population studied, has been reported between less than 1 to 18%, and males have a higher risk for developing MBL compared to females. MBL incidence increases with age, and is higher in first-degree relatives of patients with CLL. Criteria proposed for the diagnosis of MBL include evidence for B-cell clone that persists for 3 months, and there is no lymphadenopathy, hepatomegaly, splenomegaly, or autoimmune or infectious disease. MBL can be classified by the size of the clone, to low-count or high-count MBL, and by the immunophenotype, to CLL-like, atypical, and non-CLL-like MBL. The WHO classification categorizes MBL into 3 subtypes: low-count, CLL, SLL type, and non-CLL, SLL type, MBL. In low-count MBL, clonal CLL, SLL phenotype B-cell count is less than 500 per microliter with no other features diagnostic of B lymphoproliferative disorder, and can be detected in about 5% of adults over the age of 40 years. Low-count MBL has a low risk of progression to CLL, and is rarely found in the clinical practice, since high-sensitivity techniques are required for its detection. In CLL, SLL type MBL, monoclonal CLL, SLL phenotype B-cell count is 500 or more per microliter, and total B-cell count is less than 5,000 per microliter with no other features diagnostic of CLL, SLL. Individuals with high-count MBL have an increased risk of a range of adverse clinical outcomes, including progression to CLL requiring therapy at a rate of 1 to 2% per year, increased risk of lymphoid malignancies, solid tumors, and serious infections. High-count MBL is thought to be a pre-malignant state, and many of its biological characteristics are similar to CLL Ry stage 0. High-count MBL is also called clinical MBL because it is often detected during an investigation of lymphocytosis. The median number of B cells is around 3,000 per microliter. The most common immunophenotypic subtype of MBL is defined as CLL-like. The immunophenotype of the B cell clones is similar to that observed in CLL, which is positive for CD5, CD19, and CD23. With low levels of CD20 and surface immunoglobulin. Other immunophenotypic characteristics include the absence of CD79B and the weak or no expression of FMC7 and CD22. Atypical MBL is characterized by strong expression of CD20 and surface immunoglobulin along with absence of CD23. Non-CLL-like MBL is characterized by strong expression of CD20, moderate to high surface immunoglobulin expression, and absence of CD5. In cases with the immunophenotypic features of CLL, clonal cytogenetic abnormalities typical of CLL are often present. Abnormalities of long arm of chromosome 13 being found in 39% and trisomy 12 in 18% in one series of patients. 6q deletion may also be observed. The poor prognosis abnormalities, deletions of chromosomes 11 and 17, are less frequent than in CLL. Somatic IGHV hypermutation, a good prognosis feature in CLL, was present in 88% of patients in one series. In individuals with a non-CLL immunophenotype, mutations typical of non-Hodgkin lymphoma may be present. The first MBL patient for presentation is a 68-year-old man with relative lymphocytosis. In peripheral blood smear examination, few smudge cells and 10% atypical lymphocytes were observed. Patient's peripheral blood smear examination also revealed a heterogeneous lymphocytic population consisting of small, medium, and large cells, with variable amount of cytoplasm, round to oval nuclei, centrally or eccentrically placed, and with dense or fine chromatin. Rod-shaped crystalline inclusions were observed in some lymphocytes. The formation of these inclusions may be related to dysfunctional immunoglobulin synthesis. Peripheral blood lymphocyte immunophenotyping by flow cytometry revealed a pronounced increased B-cell population. B-cell immunophenotyping showed the presence of a clonal CD5 positive B-cell population with lambda light chain restriction. Another MBL case is a 69-year-old woman with relative lymphocytosis. Peripheral blood smear examination showed few smudge cells and mature-appearing circulating atypical lymphocytes with a small rim of cytoplasm, round and eccentric nucleus and clumped chromatin. Increased B-cell population was observed by lymphocyte immunophenotyping. And a clonal CD5 positive B-cell population with kappa light chain restriction was revealed by B-cell immunophenotyping. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.